everyone. We're straight back into it, and I'm now going to hand over to our very own Julia Hume, who is the Executive Director of Data Analytics here at IHPA, and she is going to introduce Professor Duckett and moderate this session. So Julia's been with IHPA since 2013, and as the Executive Director of Data Analytics, she leads the teams responsible for the functions of costing, pricing, data acquisition, and our IT infrastructure. She's worked extensively on the National Hospital Cost Data Collection, which coincidentally Professor Duckett is one of the founders of and had a very big role in getting this up and going 25 years ago, Stephen. And she holds a degree in Bachelor of Applied Science in Health Information Management and a Master's in Political Economy from Sydney University. And she's previously held roles in the health sector, including working in health insurance and cancer research. She's also worked in the international development sector in a number of post-conflict countries. So over to you, Julia and Stephen.
Thanks, James. Good afternoon, everybody, and welcome to the second session of this second day of the Activity-Based Funding Conference. I'm Julia Hume, as James just introduced me. Thank you very much, James. I'm the Executive Director of Data Analytics here at IHPA. This section that we are now entering is a unique opportunity for delegates of the conference to ask questions of Professor Stephen Duckett around the complexities of activity-based funding. Professor Duckett is the Director of the Health Program at the Grattan Institute. He has a reputation for creativity, evidence-based innovation and reform in areas ranging from the introduction of activity-based funding for hospitals to new systems of accountability for the safety of hospital care. As an economist, Professor Duckett is a Fellow of the Academy of the Social Sciences in Australia and of the Australian Academy of Health and Medical Sciences. As some of you may have viewed, Professor Duckett recorded an educational video around introduction to activity-based funding, and we'd like to invite you to post your questions in the Q&A widget on your screen, and we'll do our best to get through as many as we can in the time that we have today. While we wait for those questions to come in, I think I might start, if I may, Stephen. And this first question that I have, it's based from one of the sessions that we had yesterday. Unfortunately, I didn't get down the name of the person that asked it, but their question was, is activity-based funding an incentive for wastefulness? You know, activity-based funding is at times criticised for rewarding activity and ignoring other aspects of high-quality care, such as prevention. What do you think is the impact of this sentiment among clinicians, and how do you think it could be improved?
Thanks, Julia. A good question. So I think the answer, well, there's 4 questions, I think, or 3 questions in there. So the first one is activity-based funding and incentive for wastefulness. I would say unequivocally not. In fact, the very, very reverse. That is, if you think about it, a health service is funded for an activity such as treating a patient with an appendicectomy, or looking after someone with mental illness in the community with a particular set of attributes. And the assumption here is that, say I use the appendicectomy example, if they do another diagnostic test, they don't get paid any more for it. So there's an incentive on the health service to manage that patient efficiently, and the same is true of all of the other examples that you might give. So for the individual patient, there's an incentive for efficiency, in fact, and an incentive against waste. Then you have the other issue of is there an incentive for doing additional activity? Well, in terms of the funding from the Commonwealth to the state, that is capped at an increase of 6.5% per annum, including any activity growth. So if there is activity growth over and above that, there's no payment from the no extra payment from the Commonwealth State. Similarly, if you're looking at payments from the state to a hospital, I think in every state, activity growth is capped at, say, 2% or 1% or whatever. That might vary by the hospital. So yes, there is an incentive, depending on the design of the funding arrangement. You might have moderation, that is, you only get 50% of the normal payment if you're above your activity or whatever. So there is a tapering of the payments, so that activity-based funding doesn't involve totally and completely uncapped activity, despite the sort of the name of it. So both of those are anti-waste sort of design features. The other questions are a bit more complicated. That is, does the politics of a state mean, and the fact that you can measure and pay for additional hospital activity, mean that some other valuable activities are have underinvestment? And the prevention was mentioned, and that may be true. That is because some of the preventive activities are difficult to measure and so on, that they may be underinvested. My own view is if mental health services had been funded on an activity basis in Victoria over the last 20 years, there would have been more investment than in mental health services than has occurred, because mental health services was essentially funded on a historic basis.
Thanks, Stephen. And just one other question which was raised yesterday during Dr. Louise Schaper's presentation. And that presentation was around digital health. And the question was around wastage and the use of some high cost, high volume diagnostic type therapies like CT scans. And the delegate identified that the number of CT machines in Australia has increased 33% per million inhabitants. I haven't checked that. However, and the question is, what funds are being allocated to ensure that service provision is better aligned with best practice, and how does that also link to activity-based funding?
Well, the example given was CT scanners, and that's essentially funded on a fee-for-service basis. This is an unplanned, market-driven approach, which basically has nothing to do with activity-based funding, and as the questioner rightly points out, each additional CT scanner doesn't necessarily lead to any improvement in the health of the population, but that's not the objective of an additional CT scan. The objective of an additional CT scanner is to return an investment to the person who owns it. So the whole system is not designed to improve the health status of the population. It might be designed to improve access to diagnostic technology, but very tenuously so in my view.
Great. And now I might ask a question which has come in just this morning from Mutaza Haq. Can activity-based funding be implemented in preventive or primary care? If yes, what will be its shape and modality?
So a very good question, and I'll give you two answers. The first is yes, and the second is no. Maybe I should expand on that. So yes, it is possible to have an activity-based funding arrangement in community-based care of some kind. And so, for example, the IHPA classification systems include community mental health services, for example. And so here we are designing a classification system which is about providing primary care or community mental health services. I suppose because they are classified as public hospital services, they're at the more intense end. And so you can actually think about developing a primary care, a classification system which has activity-based funding characteristics, that is, not entirely fee-for-service, but bundling activities to look at the patient. So that's the sort of yes answer. The sort of no answer is I don't think that's the right way to go. My own view is the right way to go is more in a capitation or an enrolment direction, where in the case of chronic illness, you pay for the patient enrolls in a general practice, for example, and that the practice is rewarded, remunerated for looking after that whole patient for a particular period, such as a year. And so I think that's a better policy direction and has better attributes because it emphasises continuity and recognises the holistic nature of the treatment rather than trying to emphasise an episodic basis, which is typically where activity-based funding will take you.
Thanks, Stephen. Basil has asked this question this morning. What would your advice be to executive or middle managers in maximising and using ABF efficiently and effectively?
I think
which I think comes back to your presentation, that one of the first slides has you've arrived at your new hospital.
So this question is, I think, again, you start by saying, do you have the right information? And it is a sadness for me that many hospitals and hospital managers don't value the information that we have. In most health services, there's an incredible array of information that tells you a lot about the system. In some states, such as New South Wales and I think Queensland, the health services have got access to portals which enables them to compare themselves in terms of length of stay for appendectomies, to go back to that example, to compare adverse event rates, to compare costs, down to the clinical unit level. And so there's this amazing array of information that can be used to improve the services, either the quality or the efficiency of the services. And so the first thing you've got to do is make sure you've got access to that information. Unfortunately, that sort of information is not available in every state. And so my encouragement to middle and senior managers is to advocate that, as we know, there's all sorts of aphorisms about what you can't measure, you can't manage, and so on. So it's those sorts of things. To actually get your hands on the information is the first thing, and then start to look at it and understand both within your own service, are there differences between orthopaedic surgeon A and orthopaedic surgeon B in quality or efficiency or whatever, and similarly between your service and another service. So get the information and start benchmarking, comparing, and so on.
Thanks, Stephen. Where is it? This question comes from James Hanson. To what extent does the ability of public hospitals to cost shift into MBS limit the power of ABF in Australia? Limit the power to improve efficiency and effectiveness of health delivery?
So I don't know. I've not really thought about that. Certainly for most inpatients, maybe that's not true. The cost shifting occurs particularly at same day or non-admitted activity. And so if it is easier for a hospital to increase revenue by cost shifting than improving efficiency by improving efficiency, then they'll cost shift. But don't forget, I think the big money in hospitals will always be in improving efficiency. I don't think the big money, I don't think cost shifting will, in the end, provide the big money. And in fact, once you've done it, you've done it. And so you're going to have to go back to addressing the efficiency issues.
Perhaps on a similar vein, how can we continue to develop ABF to support better care coordination, more integrated care and innovations in hospital avoidance? At present, good programs in this space make savings to health costs, but penalise health services in terms of their ABF budgets. From
yeah, if I try and address that in a different way, first of all, we should never assume that activity-based funding is the only tool in our funding toolkit. That is, we ought to be, whenever I think I talked about in the presentation that there's both the activity-based funding arrangements and there are rules and regulations surrounding it. And so that's one point. But the other point is that typically there might be more than one funding stream. There might be a activity-based funding stream, and there might be a prevention funding stream or some other funding stream. So we should not assume that we have to, the only way we can influence health service behaviour is through activity-based funding, because as I said in answer to one of those earlier questions, you know, it might not be the right tool for what you're trying to achieve. The second component is if a hospital wants to introduce, or a health service wants to introduce a hospital avoidance program, that do they have an incentive or a disincentive to do that because of the way activity-based funding works? And the shorter answer is possibly yes, possibly no. It depends how the hospital avoidance program is structured. And it might be that the hospital avoidance program is structured as payment for a whole lot of activities, for example. So you might say, if we're concerned that, to use a very simple example, that one of the reasons people end up in hospitals is because of poor nutrition, and so you decide to run a nutrition program in the community, well, that could actually be funded as an ABF type intervention. Doesn't have to be, but it might be. So I think there is not many people, and this question sort of is an example of that, tend to think of hospital avoidance or those sorts of programs as an alternative to activity-based funding. I think they can quite easily be scoped within ABF arrangements. Whether that's the right thing to do or not is a different matter. I'm loath to recommend that people, you know, I've just been reading the National Health Reform Agreement, and there's all sorts of encouragements there for us to do things differently and to blah, blah, blah. But my own view is that trying to negotiate these sorts of changes with the Commonwealth is doomed to failure, or rather, you have to be much younger than I am to see the benefit of that, because the negotiations will take eons.
Thanks, Stephen. You touched on community health, I think, in your response to a question earlier. And my question just flipped right. Yeah, here it is. So Erin Shaw has asked, what impacts do you foresee on the introduction of ABF to community mental health in the near future, not only for funding, but for clinicians and consumers?
I think one of the things I regret, I'm on the IHPA Mental Health Advisory Group, and I regret not challenging some of the design questions or design issues in the design of the mental health classification system, which slowed down the development of that classification. So it's one of my regrets of my contributions in this area. I think that, well, first of all, I think it's an undeniable fact that all the public health services across the country underinvest in mental health services and particularly underinvest in community mental health services. So if we can get a good, robust, fair classification system that can be used to mount arguments for growth and mount arguments for more equitable distribution of resources, then I think that will help the mental health endeavour. So I think that this should be, the mental health, activity-based funding in mental health should be an engine for trying to redress the historic underfunding. That is, it is going to be easier for mental health to claim we want extra funding when it's competing on essentially the same, a level playing field with acute inpatients or non-admitted patients or geriatric evaluation and management patients. That once you've got the same metric and the same language, it's a much easier case to make that, look, we've got waiting lists just like you, and we've got service growth just like you, and we want to be funded just like you. And that's not the case at the moment. So maybe I'm a Pollyanna, but I think that's one of the potential ways in which we can argue for more investment in mental health.
Thanks, Stephen. Carly Holcomb has asked, should ABF data be more visible to the public? Are consumers aware of the cost of healthcare? And do you think expectations for treatment would change if patients understood the true cost of care?
Good question, Carly. My views on this sort of thing have changed over time. If you'd asked me that same question 30 years ago, I would have said, I think it's a good idea for us to tell individuals the cost of their health care, and that, you know, we should get a letter at the end of each year about, you know, you had one appendectomy and it cost $2,732 brackets on average, close brackets, or and that in addition you had 7 visits to the GP, and this is what the health system cost. This is what healthcare, your healthcare cost us, the community, last year. And the argument would be that making people aware of the costs and so on would make them more responsible users of health services. So I ran that line for a few years, and then I was criticised, I think correctly, by saying that there are some people who've got chronic illnesses and they can't actually, their use of health services will be huge, and they'll get this huge long bill, in inverted commas, or notification, and they'll feel even guiltier that, you know, I'm a burden on society and so on, and that we don't really want that. So I've moved away from my original position because of that argument. That's not to say that we shouldn't publish, as in fact IHPA does, that this is how much it costs on average to go to hospital, this is how much on average these things cost. And they do have a publication of that kind, and including sort of pictograms and graphs and all little graphics and so on. So yes, that some of that information is published, but not as directly, in a sense of to consumers to link their use. But I think it is a good idea to tell society that we actually spend 10% or whatever of gross domestic product on healthcare.
Thanks, Stephen. In an ideal world, how could we move toward outcome-based funding? How does this the application of ABF learnings achieve this?
So outcome-based funding is one of the unicorns of health policy. That is, we talk a lot about it, but no one has actually ever seen it. And part of the reason it's a unicorn is that it's really, really, really very difficult to do. And I'll just give you one example. Let us assume we can measure outcomes of care perfectly. And so let us assume I have a hip replacement, and that I go to a hospital which on average doesn't yield as great an improvement on the Oxford HIP score for hip replacements as another hospital does. So what, and I've got a graph that I use in, actually just does in fact show that I think it is, I've forgotten what it is, but one of Blackpool Hospital or something has a worse average increase in patient-reported outcome measures for hip replacements than Royal Alexandra Hospital or whatever it is. Now, so you know, you've got these measures that are occurring. We've got these measures, and so you can do it, and you can actually show that this hospital has a worse outcome on average. Then what do you do with that? Do you say, well, I know that on average a hip replacement costs $7,000, but I'm sorry, we're going to penalise you and only give you $6,500 for that because your outcomes are worse? Or do you give them an extra 500 and say, you know, lift your game and come back and improve outcomes? It's really, really quite tricky to work out, you know, what do you do? And my own view is you don't use a financial stick. You actually provide that information to the hospital and say, look, on average, your outcomes are worse. What is your strategy for dealing with that? And so you know, not every policy has to be in the context of activity-based funding.
Thank you. There's a question here from Joe Wright. And I know that you and I were sitting here during Professor Emmanuel's presentation. However, so the question is, the previous presentation by Professor Emmanuel talked about bundled payments for procedures being more efficient. ABF is in some degree bundled fee for service, but how much should we be looking to develop bundled payments for procedures in Australia?
So in some cases, bundled payments are actually easy to do, and we should be thinking about doing it. If I use the hip replacement example, well, no, maybe I'll start with the hip replacement example. So we know that it is possible to unbundle hip replacement care so that some aspect of hip replacement care is an acute episode and some aspect of hip replacement care is a rehabilitation episode. So we end up with two episodes for the one essentially episode. So one logical step would be to rebundle. So put the acute inpatient episode and the rehab episode back together again and have a single payment to someone, either the acute hospital or the rehab hospital, or hopefully they're in the same group or whatever, for that bundled episode. Now that makes sense if that part of the problem with bundling is what if the situation, if 100% of all hip replacement patients have rehab, that's easy because you know you don't need to, there's no gaming or other risk associated with that bundling. But if, say, 30% of patients have rehab and it is possible to determine, to predict using the patient that level data, which of those patients are in that, which patient are in the 30% and which are not, that may be possible to bundle. But it comes with a gaming risk. That is, hospitals may try to only admit patients in the 70% who don't have rehab and then get paid as if 30% of their patients do have rehab. So there's a gaming risk. But it becomes even more complex if you can't, if it's still 30% have rehab and you can't actually predict in advance where the patient, a particular patient, will fall. And so, you know, you are paying everybody as if they're going to have 30% of patients who have rehab, and there might be too much random variation to actually end up with a fair payment. Because don't forget, what we want to do is make sure the categories that are used in the activity-based funding classification are resource homogeneous and are clinically meaningful. And if there's random variation that we can't control, can't predict about who needs rehab and who doesn't, then you're going to have resource heterogeneity rather than resource homogeneity, and it will make the bundling arrangements quite different. In the United States, they started with bundling, and what they started doing was putting the doctor's bills and the hospital bills in the one bundle, which we do already.
Thanks, Stephen. I've just got a question here from Julie Lawrence, I think builds on that. Oh dear, I had the question here.
I'll just quickly respond to Lisa, who's saying about the PROMs should be incorporated in form and outcome-based funding model. In the UK, in England, to be more precise, they did collect PROMs for 4 categories: hip replacement, knee replacement, hernia, I think, of some kind, varicose veins of some kind, I forget which, but they dropped, so they did this nationwide for a long time, and as I said, I use some of the outcomes of that in some of the talks I give, but they didn't proceed with the PROMs, continuing to collect the PROMs for the varicose and hernia or whatever it is, because it wasn't seen as being useful enough. So I think we've got to be really careful, with all of these things. We should collect data which is clinically meaningful, because if you don't, if the data are not being used in the routine management of patients and the routine processes of a hospital, then they're not going to be well collected, and so we've got to be careful about it. So I think I love data. That's what I do, and I like the idea of PROMs, but I don't think we should. I think we've got to be careful and judicious in how we step into this puddle.
Yeah, I just pulled up that question from Julie Lawrence. It was about variation in care, and will there be a day where we use evidence-based pathways for appendectomy or hips, for example? There's not a lot of them available, but there is so much opportunity to standardise best practice care. Absolutely,
and I mean, I think it's inevitable, frankly, that we're going to use more standardised pathways. There was a good article a few years ago now in Health Affairs, I think it was, which was one of these top hospitals in the US, Cleveland Clinic or Mayo Clinic or one of those, and they looked at the cardiothoracic service or whatever at the hospital, and 75% of the patients that going through that hospital, Mayo, Cleveland or whatever, were treated according to and stayed on a clinical pathway. The whole point is that so even the most complex of hospitals have a huge proportion of patients who are able to be treated on and stay on a clinical pathway. Standardization absolutely improves quality of care and safety of care and everything you can think about. So, we really have to be doing much more of that. Whether every hospital needs to invent its own evidence-based pathway is another matter, but I think it's one of these inevitabilities.
Thanks, Stephen. Sorry. So Ben has asked, Australia seems to run a large number of pilots in digital health, but examples of these scaling into standard practice are few and far between. Individual hospital groups are setting targets to treat more patients at home, but how can we use ABF to support this kind of transition in a more cohesive national way?
So digital health is one of the great potential transformative impacts on the health system. To date, it has been mostly characterised by an enormous amount of waste in every dimension you could possibly think about. So obviously one has to be careful about spruiking digital health. But as you point out, telemonitoring, for example, has enormous potential. Now, one of the characteristics of activity-based funding in this country is it's supposed to be site neutral. That is, a hospital gets paid for rehab, whether for treating a patient, for hip replacement rehabilitation, as an inpatient or as a hospital in the home patient, and they get paid the same amount of money, that differently for non-admitted, for hospital in the home versus actually in the hospital. You get the same for the same patient. And so that, assuming that telemonitoring and tele-rehab and all those sorts of things are more efficient than in-hospital rehabilitation, then you automatically have an incentive on the hospital to do more through telemonitoring than you do through in-hospital. Now, the same principles apply for digital health generally. That if you know that it can, activity-based funding, because it is site neutral, I think provides an incentive for those efficiency improvements.
There's been a number of questions popping up as well, Stephen, around the public-private sectors that we have in Australia. And one here is from Simon Walsh. Under Australian ABF models, are or should there be disincentives for public health providers to perform privately funded activity in settings where there is clear evidence they cannot service existing demand?
Until a couple of years ago, we had the reverse incentive in place. That is, states were rewarded for doing more private activity. So we actually were encouraging states to do private activity. My own view is that, well, that incentive has been mitigated. I haven't actually done the algebra again since the agreement changes, but I think I hope it's been eliminated, and so that the financial incentives are cost neutral to a health service state for admitting either a public or a private patient. Now, the assumption of the question is that private patients should go to private hospitals. One of the problems of the Australian healthcare system is if you go to a private hospital, if you have private health insurance, your out-of-pocket costs go up. And so that people who have private health insurance are taking on not only the costs of premiums, but also the out-of-pocket costs associated with it. And until the private health industry, and in all its elements, the doctors, the insurers and the hospitals, for example, get their act together and provide a product that doesn't give patients surprise bills, I think many private patients will want to go into a public hospital because they're worried about the private bills, the out-of-pockets they might incur if they go to a private hospital. They might go into a public hospital because the care they want is not available in a private hospital. They might go into a public hospital because they have significant, they've signed up already for, they've only signed up for a particular level of care which provides care in public hospitals. So there's a whole host of reasons why they might go into a public hospital.
And a further question to that from Michael Reynolds was, is ABF a useful tool in policy mapping in the public-private hospital resource debate? So how can we use that?
My own view is that the future for private hospitals should be that they get paid on an activity-based funding basis, and IHPA should set the price, set a price, an ABF price for private hospital activity, which should bundle in, amongst other things, prosthesis costs, and hopefully also doctor costs, on the bundling argument we had a little discussion about before. And so, but at the moment we have whatever it is, 48 health insurance funds, each entitled to set their own pricing policies, and private hospitals have to negotiate and understand what the limitations are of each fund and so on. So it's a real dog's breakfast. But what the outcome is that private hospitals are essentially less efficient than public hospitals. The patients in private hospitals stay longer. Sorry, I shouldn't have said less efficient. What we do know is that patients in private hospitals stay longer. I think that's because they're less efficient. Private hospitals say that's because that's the service we offer. That is, we're more relaxed and you can stay longer after your maternity episode. And the taxpayer and the other private health insurance contributors should pay for that, because that's a good thing, on my view.
Thanks, Stephen. There's a number of questions which have popped up in the feed around funding and activity-based funding of small or remote facilities, and it references the national efficient cost, which IHPA has develops, determines each year. So here's just one of the questions, but perhaps you could just touch on this area. What are your thoughts regarding NEC funding in very remote settings in Northern Australia, which tend to end up with fixed block funding from the state? How do we incentivise improvements in these settings with very high costs of service delivery?
So there are too many elements to that question. First of all, the national efficient cost is essentially for hospitals' sites which are too small to be funded on a purely activity-based funding national efficient price basis. And there might be a number of reasons for this. It might be that, you know, they've got a high level of fixed cost compared to their variable cost. You know, that if you've got less than 30 beds, for example, 20 beds, you're going to have X number of nurses on every day, regardless of how many patients you've got there, and you can't afford to pay for the nurses on an activity-based funding basis. So that's why the national efficient cost came about. And over the period that IHPA has been in existence, they've evolved the way they calculate the national efficient cost, and so it's a more accurate, a better model for payment. And so if you're going to have a national efficient cost sort of approach, it's a better approach now than it was a few years ago. Now the question is that the right approach? And it again links back to the question that we talked about a little while earlier, that, you know, some of these hospitals are essentially primary care services, and that you've got to think about what should be the model of payment to encourage the sort of care and service provision that you want in those communities. And it might be best to say, I know the community wants to have the label hospital on this building, but really we should be thinking quite differently about what sort of payment arrangement and what the job of this service is, and whether activity-based funding is at all the right thing to do, or whether we should be having some sort of population-based funding for these smaller communities.
Thanks, Stephen.
I hope people who have got, I thought this was going to be about introduction to activity-based funding. What it's turned into is a question answer about activity-based funding policy. I don't mind, but I do hope those newbies who have introduction type questions feel free to ask them.
There are a lot of questions coming through, and I am trying to. Maybe we'll have to. We can always we'd love to hear feedback on the video actually, and how
we were going to do 3 videos for different aspects, but we ran out of time, or I ran out of time, and we were just a toe in the water sort of thing. So
yeah, so any feedback on those is very welcome. What are your, so from ABF Commonwealth to states and states to LHNs, hospitals funding is well established, ABF is well established. What are your thoughts on using a similar model for hospitals to allocate funds within divisions or clinical areas within the hospitals?
This is a huge issue, and there's no right answer. So basically, what you're interested in is accountability, and this then comes to your organisational structure. So and different hospitals, for cultural reasons and so on, might solutions about this. So, for example, one hospital A might say, we are going to have an organisational structure which has a very traditional one, where there is a directorate of nursing, medical services, imaging, or whatever. And there's clear professional accountability within the nursing hierarchy for nursing care, and this might be argued to promote quality of nursing care and so on. If you have that structure, you actually, it's really hard. You can't actually do an ABF type modelling inside the hospital. On the other hand, you might say, we are going to have a cardiothoracic division, and they are going to be responsible for a cardiothoracic budget, and we'll have internal charging arrangements for diagnostic imaging or pathology services or whatever it is. And so you could actually give the cardiothoracic division a budget based on activity-based funding, and you can have any combination within. There's lots and lots of combinations you can have. But my own view is, regardless of whether you use it for budget allocation and accountability purposes, you ought to know whether cardiothoracic services, to use that example, in your hospital are more expensive or less expensive than in any other public hospital. And the board ought to know whether it is subsidising cardiothoracic services, whether the cost of cardiothoracic services in your hospital are more expensive than the revenue you're getting from the activity-based funding arrangements. So, it certainly is a powerful piece of information that ought to be used within hospitals. Certainly, the clinicians ought to be able to compare the cost of heart catheterisation or whatever you're going to do in your hospital versus another. That's why the portal is really important. But how you actually manage internally within the hospital and whether you allocate budgets based on activity-based funding is as I said, an issue that you could talk about for days to come. Unfortunately, in a video, a virtual conference, you can't talk about this over the bar, but it is really a quite interesting issue. And also, there are some technical issues because, if you once you're doing internally, you end up with small numbers, and so you end up with problems of instability in the data.
Thanks, Stephen. Sorry. There seems, Lee Matthews has asked, there only seems to be one meta-analysis that reviewed the impact of ABF around 2014, I think.
Of which I'm a co-author.
So, is there any recent research that quantifies how effective ABF is in stabilising cost growth in the public system?
As I said, that was, if it's the one I think you're referring to, we published that in PLOS 1 a few years ago with Karen Palmer as the first author. Well, these things take a lot of time to do and involve an army of coders and of people to classify things, and so we had an army, all of whom are co-authors. So I'm author number 723, I think, of that study. So no, I haven't seen it done again, and it is really a very hard counterfactual because, yeah, it does require before and after studies and so on, and it's too late for that in Australia.
A question here from Attic. How can ABF control the number of admissions as unintended consequences of the payment system? How can we make sure that the national budget covers off all of these annually? So I think the question is around high volume of activity resulting in increased readmissions.
So what is it that we somehow are
an unintended consequence?
It might be that the activity-based funding encourages a shorter length of stay, which might mean there's a higher readmission rate. Is that the argument?
Yeah.
Yeah. We looked at that when we introduced activity-based funding in Victoria and didn't find it, by the way. Everybody said that was going to happen, but we didn't find that. And the meta-analysis we referred to didn't find that either. They found the big finding was the unbundling, rehab admissions went outside. Obviously, the measurement of readmissions is a really tricky one because it's the window you use for calculating the readmission rate is very, very sensitive, and you might need different windows for different conditions and so on. So yes, it is possible to sort of have a bundled approach that, and in fact, I think isn't Geisinger healthcare in the United States? They have the Geisinger guarantee that if you have your heart procedure, I think it is, or maybe it's the hip procedure. If you have a procedure at Geisinger, the Geisinger guarantee means you have a lifetime cover. That is, if you are readmitted because of that operation, it's free. They cover the cost of all readmissions for your lifetime, which I think is pretty dramatic, and be good to actually do that here for some hospitals too.
Stephen, we've only got a couple of minutes left. So here's another question for you. Does activity-based funding provide a disincentive to hospitals to introduce interventions with evidence of additional benefit, but a high or very high cost? We can see this in some new medicines and prostheses, because the amount paid under ABF is based on 2 to 3 year old data, when the new high cost intervention was not in practice.
Well, prosthesis is a bad example because new prosthesis generally perform worse than old prosthesis on average. But the point is a good one. That is that we have to make sure that ABF updating arrangements do not inhibit good, effective innovation. And to some extent, that is a responsibility of the states. That is, they have to, because they're more nimble than a national arrangement. But also, I think IHPA has a policy that you can actually put a case to IHPA to say, look, the evidence is now clear. Here are the randomized control trials. We should be doing X within this DRG. And so the price, the 3 year old data is not the right data for setting this price. I forget what their policy is called. I'm pretty sure I'm right on that, Julia, aren't I? But I don't know whether it's that yes, we need to make sure that we are not inhibiting innovation, sensible innovation, because of that lag.
Yep. We do have mechanisms for that.
I reckon the Downing and Duckett guarantee is a really good thing.
Yeah, I'm happy to sign James up to a... I can hear James calling out about signing up to a guarantee. One last question, if I may, and this one is also from Joe Wright. The best hospital avoidance program is comprehensive primary care, particularly if integrated with the regional hospital. How can we move in that direction in Australia?
Oh, Joe, I mean, what a terrible question. So I think that it's partly attitudinal. I chair the board of a primary health network, and the message that our board is sending to the staff and to everybody is that we think it's really important to work closely with the health services, and we want to try and be as close with the health services in our area as we can possibly be. And so it's an attitudinal thing, but it's also a policy thing. That is, the Commonwealth government ought to be saying to the PHNs, you've got to work closely with your health services and we're going to help you do that. And the state needs to be saying to the health services, you've got to be working closely with the PHN and we're going to help you do that. So we really need tripartite arrangements between the PHNs, the health services, the Commonwealth and the state to send the signal that we really want. We've got these funding arrangements that exist in Australia, but let's try and do whatever we can to provide a high quality, integrated, prevention oriented health service.
Thank you, Stephen. So that's going to be my last question. I'd like to thank everyone who has participated by sending questions in today. And thank you very much, Stephen. The video is available and we will ensure that it's available on IHPA's website, and we welcome feedback. And I think James might be popping back in now.
Julia
Thanks.
and Stephen, and I certainly am going to give some thought to the Duckett Downey guarantee. Some awesome questions there and some really good answers. I'm not quite sure which one I enjoyed most. Stephen, am I young enough to, if I start now on primary care capitation? Right, so once again, it's time for people to exit back to the timeline, and then it will be time for our clinical panel at 1 o'clock. So you've got 3 minutes to grab a glass of water and freshen yourself up. So we'll see you back with Sophie Scott and our clinical leaders in 3 minutes. Thanks very much, Stephen. Thanks for your time, and thanks very much for the video. And thanks to everyone who entered a question.